Hi, this is Dr. Neurosurgery Greenberg, and today we are going to talk about specific types of pituitary tumors, which are the non-functioning pituitary adenomas. They are those tumors which do not produce any signs or symptoms as a result of hormonal hyposecretion. It means that there is hypersecretion, there is some gonadotropin or gonadotropin subunit secretion, but they do not produce any endocrinologic harm. Then there are gonadotropin tumors. If they secrete FSH, then ovarian hyperstimulation syndrome in the female can occur, and in the male, it can lead to testicular hypertrophy. And if there is more LH, then it can lead to precocious puberty. Here, it is important to remember that precocious puberty is most commonly caused by hypothalamic hamartomas. Then, prolactinomas are another type of lectotroph tumor, and its manifestation are Forbes-Albright syndrome, or it is also known as Alhamada del Castillo syndrome, and it leads to oligomenorrhea, irregular menstrual cycles, and you have to first of all rule out pregnancy in any female coming with secondary amenorrhea. Then in the male, it will lead to impotence and little bit of feminine body and small testicles. Then, in both sexes, it will lead to infertility and bone loss, osteoporosis in female, and both cortical and trabecular osteopenia in males. And usually in women, in microadenoma stage, prolactinomas are discovered because of their characteristic oligomenorrhea and other difficulties, whereas in males, they become a little bit larger before they are detected. Now we come to Cushing disease. So, what you need to understand is that there is a term called Cushing syndrome. It is a constellation of findings caused by hypercortisolism. Now, why has this cortisol become so high? There are many reasons, but if the reason is that a pituitary adenoma has secreted more ACTH and that has caused the adrenal medulla to release more cortisol, then it is called a Cushing disease. That is the cause of the Cushing syndrome. If it lies in the pituitary, it is Cushing disease. And also you must remember that in most cases, there is actually exogenous administration of steroid, which has led to cortisolism, hypercortisolism in people. That is the most common cause. Now, there are four main types of etiologies that can lead to hypercortisolism, as is shown in the table. So, first we have discussed that it is a pituitary adenoma, which is leading to excess production of ACTH, and that is causing the Cushing disease. In it, the secretion product is ACTH, and most common is pituitary adenoma, and ACTH levels are only slightly elevated. But sometimes there is ectopic ACTH production, most commonly the lung tumor and pancreatic tumor. They are also going to secrete ACTH, but here the ACTH is going to be many times elevated. Then there is adrenal medulla problem, which has led to excess cortisol. It is not bound to any level of ACTH. In fact, the pituitary will try to decrease its ACTH because it is sensing the cortisol. But as the cortisol production is independent of ACTH in ectopic production, that is why the cortisol will be the secretory product. And in it, ACTH level will be actually low. Then there is a pseudo Cushing state in which the real cause is in the hypothalamus, not in the pituitary. So over here, actually the pituitary is fine, but it is being stimulated by the hypothalamus paradoxically or pathologically by the excess CRH. And the excess CRH has led to an increase in ACTH and an increase in cortisol. So these are the four types of Cushing etiologies. So if there is ectopic ACTH secretion, then actually the hypercortisolism is due to ACTH secretion by the pituitary by the lung tumor or the pheochromocytoma or the pancreatic tumor. Okay, and it can also be due to medullary thyroid carcinoma. So usually when there is Cushing disease, the pituitary tumor is very little. It is less than 5 mm, and it is very little, so little that it cannot be seen on the CT or MRI. And if you try to stain them, then most are basophilic, and some, if they are very large, then they will be chromophobic. And they only have to be, actually, they have to be very little to produce the Cushing disease, and they are a very, very difficult tumor to handle. So, what are the clinical findings that you will find in Cushing disease? So there is Cushing facies, which is moon facies. There is increased urinary free cortisol and increased glucose. There is sepsis and a buffalo hum, hypertension and hyperpigmentation. The hyperpigmentation is actually because of MSH cross reactivity with ACTH. And ACTH, whenever ectopically or due to pituitary, when it is increased, then and only then you see hyperpigmentation in Cushing syndrome. Then there is a neoplasm. Okay, it is mostly caused by a neoplasm, and then there is glucose intolerance. Other than that, the skin is like a tissue paper thin skin. It is easy to bruise and it will have poor healing. There is osteoporosis and there is easy fatigability, hirsutism, acne, and what you will find in the lab findings is hyperglycemia, hypokalemic alkalosis, and a loss of diurnal variation in the cortisol peaks. Actually, in the morning, the cortisol is at its peak at 7 8 a.m. But if you look at it at 11 p.m., the cortisol falls. So if the day and night peaks are lost, then it is the seen in the Cushing disease or syndrome. And if you want to say it is hypercortisolism, then you have to do the screening test, which is 24-hour urine free cortisol, and it will be raised. Then we come to Nelson syndrome. So it is a rare condition in which after total bilateral adrenalectomy, which you have performed for Cushing disease, will lead to actually a paradoxical resumption or even hypersecretion of cortisol. So actually it's not cortisol, it is increased ACTH. And what happens is that actually you have done total bilateral adrenalectomy. So you found that there was Cushing syndrome, and you found out that the cause was the adrenal medulla, and the adrenal medulla was producing more cortisol. So you did bilateral adrenalectomy. Now the hypothalamic and the pituitary axis is still intact, but the body has no cortisol. Now you have tried to supplement that cortisol with the help of tablets. Okay, you give prednisolone, you give whatever steroid, but the body senses that there is not enough cortisol. So hypothalamus asks the pituitary to secrete more ACTH. And now, because of more ACTH, there will be hyperpigmentation, and the pituitary will make a new adenoma. So Nelson syndrome is due to continued growth of corticotroph adenoma cells, which occurs 1 to 4 years after total bilateral adenectomy. And what happens is that following the total bilateral adenectomy, hypercortisolism resolves and CRH levels increase back to the normal from the reduced state. But corticotroph adenomas in patients with Nelson syndrome have an increased and prolonged response to CRH, which results in increased growth, and you will see hyperpigmentation because of the increased ACTH in the linea nigra and the scars, gingivae and the areolae, and then there is tumor growth. The pituitary adenoma becomes bigger. Then there is malignant transformation of the corticotroph tumor, and then there is sometimes, even if there is some kind of adrenal rest, like in the testes of some males, there are adrenal rests and they start producing the cortisol. So what you will find is that ACTH is very much increased. Normal value is less than 54 nanograms per liter, but here the ACTH will be more than 200 nanogram per liter. And if you give CRH, then it will have an exaggerated ACTH response, and other pituitary hormones may also be affected. And if you do visual testing, then you will see that there are some changes. So that is all for today. I will see you in the next video. Thank you and God bless.